Welcome to this explainer. You know, it's wild to think about, but a single miscoded operative report can actually delay critical life-saving care. It's a massive challenge we face every single day, translating the complex, beautiful biological blueprint of cranial anatomy into the exact rigid maps of medical coding. It requires immense precision, and today we're going to master that exact process together. Okay, so here's our game plan for today. We're going to cover the precision principle, navigate through cranial anatomy, explore the concept of the two-floor brain, break down some core cranial terminology, and wrap up with key documentation takeaways. Let's get right into it. Starting off with Section 1, the precision principle. So before we even touch an operative report, we've got to get into the right mindset. This isn't just about reading words on a page, it's about spatial awareness and understanding the surgeon's exact route. Think about this for a second. Why is neurosurgery coding exactly like using a GPS? Imagine jumping in your car to get to a super important, life-saving destination. If you don't plug in the exact location, you're literally just driving blind, guessing at every single turn. It's a perfect analogy, right? Just like your GPS needs a highly specific street address, not just a broad city name, to keep you from getting totally lost, assigning the right neurosurgical procedure code demands exact anatomical specifics, rather than just a vague surgical region. Here's the really interesting part. Knowing the tumor type, let's say it's a meningioma, well, that just gives you the city. It's a start, sure, but it is absolutely not enough. To get the true, precise street address, you have to dig deeper. You need to uncover the surgical approach, the exact depth of the lesion, and the specific structural location. Every single detail in that operative report acts as a vital coordinate. All right, moving on to Section 2, navigating cranial anatomy. Now that we've got the precision principle locked in, let's actually build the biological blueprint that the surgeon navigates in the OR. This surgical path is never random. It's a very deliberate, layer-by-layer journey. First, the surgeon starts at the skin. Next, they cut through the solid bone of the skull. Then they carefully open up that tough, protective lining called the dura. And finally, they reach the delicate brain tissue. Throughout this whole process, the absolute priority is reaching the problem area while causing the minimum amount of trauma to the healthy tissue around it. Once the surgeon is inside, they encounter the skull base. You can think of this as the floor of the cranial cavity. But here's the thing, this floor isn't just flat. It's actually divided into 3 distinct structural regions, or fossae. And understanding these regions is a huge deal because it fundamentally dictates the surgeon's operative approach. Each of these 3 regions houses some absolutely critical passageways. Try to mentally map this out with me. Right at the front, near the eyes and nose, you've got the anterior cranial fossa, which is home to the optic canal. That's what carries the vital vision nerve. Now, move back a bit to the middle, near the temporal lobe. That's the middle cranial fossa, where you'll find the cavernous sinus. This is a massive intersection for nerves controlling eye movement and the carotid artery. Finally, way in the back, near the brainstem, is the posterior cranial fossa. This area contains the giant foramen magnum, which is exactly where the spinal cord meets the brainstem. For us as coders, knowing precisely which fossa the surgeon is working in is completely crucial. Which brings us to Section 3, the two-floor brain. Let's talk about a concept that fundamentally changes how we categorize and document cranial lesion removals. It helps to think of the brain as a 2-story house. It's physically separated into an upstairs and a downstairs by a structural ceiling made of dura called the tentorium. Now, where the anomaly is physically located, whether it's upstairs or downstairs, completely dictates which door the surgeon uses to enter the house. So the golden rule here is to always ask yourself, is the surgery happening upstairs in the supratentorial region or downstairs in the infratentorial region? If it's upstairs in the cerebrum, where thinking and memory live, the patient lies face up and the surgeon goes in from the front or the top of the skull. But if it's downstairs in the cerebellum or the brainstem, the areas regulating balance and breathing, the patient lies face down and the surgeon goes in from the back. That one single structural distinction literally changes the ultimate procedure code. And when they are operating downstairs in that infratentorial region, surgeons often have to navigate what's called the cerebellopontine angle, or the CPA. This is an incredibly sensitive structural intersection tucked deep down near the brainstem, the facial nerve, and the 8th cranial nerve, which handles hearing. Working in the CPA requires extreme precision. Even a microscopic slip up here can cause devastating injuries, like severe hearing loss, facial paralysis, or life-threatening hemorrhage. Let's dive into Section 4, core cranial terminology. Now that we know the layout of the house, let's look at the specific actions the surgeon takes once they've reached the correct room. The terminology here is incredibly precise, and the suffix of the procedure holds the absolute key. If a surgeon temporarily opens the skull to access the brain and then replaces that bone flap at the end, that's a craniotomy. If they remove a piece of bone to relieve intracranial pressure and purposely leave it off, that's a craniectomy. If they're reconstructing a defect in the skull using bone or synthetic material, we call that a cranioplasty. And if they simply drill a tiny access point to drain fluid or establish an entry, that's a burr hole. But as coders, we have to apply this exact same strict precision when the surgeon operates directly on the nervous system. These nerve-specific terms are essential. First, you have to distinguish neuroplasty, which is the careful repair or reconstruction of a nerve, from neurophy, which specifically means suturing a completely severed nerve back together. If the surgeon intentionally cuts or divides a nerve, that is a neurotomy. If they are carefully freeing a nerve from binding scar tissue, that action is called neurolysis. And finally, if they are relieving physical pressure on a compressed nerve, that's documented as a peripheral nerve decompression. The exact surgical action always dictates your code. Jumping back to the skull for a second, beyond just manipulating the bone, surgeons face a critical decision when planning their route. Do they need to break down a structural wall, or can they simply use an existing window? Breaking the wall means performing a full craniotomy. This involves a larger external opening, giving them broad direct access to the brain, but it inherently causes more tissue disruption. On the flip side, using the window relies on a transsphenoidal approach, literally navigating right through the patient's nose. This offers a quiet, direct route to areas like the pituitary gland without opening the skull whatsoever, resulting in far less trauma and a much faster recovery for the patient. Bringing us to Section 5, Key Documentation Takeaways. So we've mapped the anatomy, the structural floors, and the exact surgical actions. Now let's tie the whole shebang together. The operative report is your absolute source of truth. Your best bet is to always isolate the primary procedure first, like a tumor removal, for example. Once you have that, meticulously scan the narrative for any secondary actions. Did they do some extra spinal fluid drainage? Did they harvest any grafts? Were they using specific navigational guidance or a microdissection microscope? And of course, you must constantly verify the precise location. Is it anterior or posterior? Supratentorial or infratentorial? Let me show you just how crucial these secondary details can be. Say the surgeon is closing a spinal fluid leak by repairing the dura. Precision dictates you have to know exactly how they did it. Did they use a free tissue graft? That means the tissue was completely detached from another part of the body and relocated without its original blood supply. Or did they use a vascularized pedicle flap? That's where the relocated tissue actually keeps its original blood supply, staying attached for optimal healing. The documentation has to give you that exact answer. As we wrap up this foundational explainer, I want you to think about everything we just walked through. We traced the surgeon's path from the skin down to the brain, explored the complex anatomy of the cranial fossae, and locked down those critical differences in surgical terminology. Every single one of those details is a precise coordinate on your map. Thank you so much for joining this explainer. The next time you sit down with an operative report, I leave you with this challenge. Are you settling for a vague city name, or are you actively hunting down the exact surgical address? Settle for nothing less than absolute precision. Decode healthcare with Harshal.